All right, good evening, everyone. I'd like to welcome everyone to tonight's Journal Club meeting. My name is Justin Chu, and I'll be serving as the club advisor moderating tonight's Journal Club meeting. So I am a recent graduate of University of Louisville Fellowship, and I stay there now as faculty in sports medicine. And just to discuss the AMSSM Journal Club. The goal of the Journal Club is to provide a national platform for student and resident members to present an article from the list of the top 120 articles that sports medicine fellows should be familiar with. Our intent is to make this a fun learning experience to give medical students and residents mentoring opportunities with other AMSSM members while developing skills of reviewing articles and making PowerPoint presentations. Tonight, we'll have two presentations. The format for the Journal Club meeting is that each presenter will have approximately 20 minutes block of time that includes a brief question and answer segment after the presentation. Please enter your questions using the chat function, and I will read the questions entered in the chat and ask the presenter and their club mentors to respond. And first, I'm pleased to introduce our first presenter tonight, Dr. Blake Barton, and his club mentor, Dr. Mark Troxler. Dr. Barton is a PGY4 fellow mid-peds resident at the University of Tennessee Health Science Center in Memphis, Tennessee. He's applying to primary care sports medicine fellowship this fall with interest in endurance sports and collegiate athletics. Personally, he enjoys staying active, running and cycling with his wife, Becca, his son, Henry, and golden retriever, Moose. His presentation is on the article, Chronic Lower Leg Pain in Athletes, Overview of Presentation and Management. I'd like to thank Dr. Mark Troxler for serving as his club mentor. Dr. Troxler is in private practice at McKinney Internal Medicine and Sports Medicine in McKinney, Texas. He's the chairman of Anti-Doping Education Committee for USA Track and Field. He has served as a team physician for youth, high school, college, Olympic, and professional athletes. He completed medical school at Oklahoma State University College of Osteopathic Medicine in Tulsa, Oklahoma, and completed his internship year of residency at Hillcrest Health Center in Oklahoma City, Oklahoma, and his internal medicine residency at the University of Oklahoma College of Medicine, Tulsa campus in Tulsa, Oklahoma. Dr. Troxler completed his sports medicine fellowship at Jersey Shore University Medical Center and Rutgers in Neptune, New Jersey, and he received an MBA degree at the University of Massachusetts Amherst campus in Amherst, Massachusetts. And I will turn it over to Dr. Barton now.
Okay. So we'll go ahead and get started. I know we're kind of waiting for some more people to join, but like they said, my presentation's on chronic lower leg pain in athletes. Pretty hefty presentation overall. So it's going to be a very broad overview, but we'll go ahead and get moving. So this is a review article published in March of 2019 in the Hospital for Special Surgery Journal. Like I said, a review article. So, some updates that we could have in the last 4 or 5 years, but I think still very relevant to us. And then just talking some objectives here. So number one, identify some common causes of chronic lower leg pain in athletes, identify and review some common symptomatic therapies. 2, discuss some appropriate imaging modalities to diagnose those etiologies of lower leg pain. And then discuss when surgical intervention and referral is going to be needed. And then kind of throughout the talk, I'll kind of briefly discuss some anatomy and then surgical outcomes as well as we go. So introduction methods. Chronic lower leg pain is something that affects all demographics, and the differential diagnosis can be broad. Symptoms can often be ambiguous, which is why I think a talk like this is important. And then, we're all pretty familiar with the compartments of the lower leg. We won't go through the nitty-gritty details, but kind of helpful to set up a framework here. So anterior compartment, lateral compartment, and then superficial and deep posterior compartments we'll kind of go through. And then, like I said, this is a review article. So systematic reviews and meta-analyses were conducted, and then the search terms were related to diagnosis and treatment of athletes with chronic lower leg pain. So 2 independent reviewers kind of started with 275 studies and then eventually whittled it down to the 88 that kind of make up our review article here. And then again, kind of setting up the framework. So they break it into 3 buckets. You have your bony etiologies, your soft tissue etiologies, and neurovascular etiologies. And I think just as kind of a 5-minute summary looking at this topic, I think this is a fantastic resource. So I think this will be this table will be something that I go back to in the future when I have a patient that presents with this type of complaint. So we'll go ahead and get started with the specific etiologies here. So medial tibial stress syndrome, otherwise known as shin splints, something that's very common in sports medicine clinics. Patients are going to present with diffuse pain at the posterior medial border of the tibia associated with activity, relieved with rest. Pathophysiology can kind of take your pick of the theories here. So periosteal remodeling, tendinopathy of the anterior compartment, bone turnover issues are kind of all theorized. Some risk factors: hyperpronation, plantar flexion, limited hip internal external rotation, kind of the extremes of BMI, and then female sex is also a risk factor as well. And then diagnosis is typically clinical. And then if you do get an MRI, you may see some cortical thickening and reactive edema at the site. So here on our axial view, you can kind of see some edema on this T2 image along the medial tibia, and then kind of same thing longitudinally on this view here. And then treatment, typically it's going to be activity modification, rest, ice, and then gradual return to activity. And if you do kind of proceed down the surgical pathway, which is fairly uncommon, the surgical outcomes seem to be fair, not great. I would say the study mentioned reduced pain levels in 72% of those who undergo surgery, but that return to high-level sports is not always guaranteed here with fasciotomy or periosteum release. And then kind of continuing down that path for bone stress injuries, we have tibial stress fracture. This is something I'm familiar with from my own marathon training in med school. I had a medial tibial stress fracture. So presentation is going to be more focal tenderness and edema, most commonly at the posterior medial or the anterior cortex of the tibia. Pathophysiology, you're going to see changes in intensity or duration of activities like running are going to lead to bony resorption and microfracture that lead to the stress injury. Diagnosis is clinical, and then plus plain radiograph with a star here, with the caveat that you may not see changes on X-ray until several weeks after the injury. So MRI is kind of the gold standard there, even over bone scan. MRI here, you have a T2 image, lateral tibia, where you see some bone marrow edema, cortical changes, and then actually a linear fracture line through here that would make this a grade 4 stress injury, grade 4B. And then we'll kind of go over the classifications on the next slide. Surgical referral are going to be for things like non-union athletes who may require plating to get a more quick return to activity. And particularly the high-risk ones, I believe, are the anterior stress fractures. But with surgical management, symptom resolution and return to athletic activity is like 90 to 95%. So pretty good outcomes there. And then a note on the Fredrickson classification system. This is pretty classic for grading stress fractures. Your grade 1 injuries are just going to be periosteal edema on your MRI. Grade 2, you're going to start to see marrow edema on the T2 imaging. Grade 3, you're going to see more extensive bone marrow edema, and that's going to be visible on your T1 and T2 sequences. And then grade 4, you're going to start to see areas of cortical changes. So that's 4A, and 4B is going to be all of these changes with an addition of a fracture line. So when we talk about return to play, your grade 1, 2, and 3 injuries are more that 4 to 8 week range. And then you start looking at 8 to 12 plus minus surgery involvement when you get to these grade 4, particularly 4B. And for myself, I was out 12 weeks with a 4B, so not fun for anybody. Moving on to kind of tendinopathies, there will be several of these. So Achilles tendinopathy, another very common injury. The anatomy is this is a common shared tendon by the gastroc, the soleus, and connects to the calcaneus posteriorly. Your patient's going to present with posterior ankle pain, may or may not have swelling. Typically, it's going to be worse with loading, improve with rest. And the study cites up to 9% annual incidence for runners, so very common. And then the majority of injuries, up to 65%, are kind of at the mid portion of the Achilles, kind of 2 to 7 centimeters from the insertion. And then another 20 to 25% are going to be the more insertional tendinopathies. The risk factors are going to be poor training patterns, poor footwear, running on slanted surfaces. So patients will want to be careful with kind of the camber of the roads they're running on as well. Clinical diagnosis, primarily, if you get an ultrasound, it may show thickening of that area, neovascularization, hypoechogenicity. So here we have an ultrasound image. You can see the right compared to the left here. You've got a thickened right Achilles tendon with some disorganization, kind of loss of this fibrillar structure we see here. And then this is just kind of a blown up image of that thickening on ultrasound. Treatment here, you've got NSAIDs, shockwave therapy has some good data, as well as eccentric exercises, and then proceeding down the surgical pathway to tenotomy, whether in a sports clinic or orthobiologics like PRP. And then surgical referral is going to be more complex for open tenotomy, tendon augmentation, and transfer. And, particularly for us as sports medicine, non-operative sports medicine doctors, about 96% of patients get complete symptom resolution with minimally invasive debridement. So I thought that was kind of an important point there. So next, perineal tendinopathy. If we're looking at the anatomy, we have the longus and the brevis tendon through here. So the anatomy is up here. The longus muscle goes from the lateral condyle and proximal fibula to the base of the first metatarsal. And the brevis goes from the distal fibula to the proximal fifth metatarsal. Patients are going to have pain and swelling posterior to the tibia. They may have pain with resisted eversion, passive inversion. I've kind of marked out the area with an arrow of where you may commonly see pain. And this is kind of caused by these tendons at this area being in close proximity. So you've just got repetitive stress and compression of the two tendons causing inflammation. Diagnosis, the study mentions that MRI is going to be greater than ultrasound. And again, you may see some typical ultrasound findings like thickening, hypoechogenicity, neovascularity. And then the image they give you here. So this is a proton density fat saturation image. You've got some thickening of the longest tendon here on the bottom. And then you have actually a longitudinal tear in the brevis tendon, kind of forming this Mickey Mouse ears sign is what they talked about in the study. And then treatment, you may need to immobilize this patient, but otherwise conservative therapy is going to be PT, NSAIDs, and icing. And then surgical referral for debridement and synovectomy, although they don't really comment on what the outcomes are like for this. So next, flexor hallucis longus tendinopathy, another one, unfortunately, I'm familiar with. So kind of moving towards the posterior compartments of the lower leg here. The muscle itself is shown as retracted in this image. So this originates from the posterior and distal fibula, runs down through the tarsal tunnel, kind of crosses over and attaches to the base of the first MTP. This is commonly called dancer's tendinitis. So you may see a dancer or a runner with posterior medial ankle pain. And then also in my case, you may see kind of at the base of the MTP here because it crosses under the flexor tendon. So you may see some irritation there as well. And then diagnosis is going to be clinical plus or minus an MRI that you may see capsular thickening, enhancement of this area. So on the coronal here, you've got a T1 image with some enlarged flexor hallucis longus tendon here. And then on this view, you have some lobulated fluid collection kind of posterior to the tendon, kind of indicating that tenosynovitis. And then treatment here is going to be rest, ice, NSAIDs, PT, kind of similarly to the others. And then tenolysis may be something that's pursued after 6 months or so of failed conservative management. And they mentioned that the outcomes, about 89% of cases have satisfactory outcomes, and then return for high-level dancers is up to 16 weeks. So could be a pretty significant injury there. Tibialis posterior dysfunction. So the tibialis posterior originates on the posterior lateral tibia, as well as the posterior medial fibula. Again, moves through the tarsal tunnel attaching to the navicular. Presentation for these patients may be more the obese middle-aged type of runner, and they can really see pain anywhere throughout the course, they comment, all the way down through the tarsal tunnel there. Ultrasound is going to be preferred primarily due to cost effectiveness and ease of accomplishing that in clinic compared to MRI. And you may see some hypoechogenicity kind of surrounding the tendon. Treatment, immobilization may be helpful here. Footwear modifications are going to be big, particularly because the posterior tibialis kind of supports the arch itself and helps with plantar flexion, inversion of the foot. And then special note about surgical referral, they mentioned that it should only be done in those less than 50 years old. I'm not really sure why they didn't so much go into that, but may perform a debridement and tenosynovectomy if indicated. And then here's our MRI image here. So you have a proton density image showing the thickened tendon here, kind of at the medial tibia. And then on this second image here, this is our fat saturation image. This really shows well the kind of the osteitis, bone marrow reactive edema from the inflammation at the tendon site here. So I thought that was interesting to show. And then moving on to our anterior compartment, you have the tibialis anterior tendinopathy. So originates from the lateral condyle and the upper 2/3 of the tibia attaches to the first cuneiform as well as the base of the first MTP. This again can be the obese middle-aged athlete. They're going to have anterior ankle pain along the tendon course all the way down to the extensor retinaculum here. They may have decreased dorsiflexion, painful plantar flexion as well. And the pathophysiology here is going to be kind of recurrent stress leading to breakdown, disorganization. Diagnosis like the posterior tib is going to be ultrasound preferred just due to ease of use in clinic and cost. Treatment, activity limitation can be big here. And they mentioned that RFA and shockwave therapy can be helpful here. Looking at an image, again, they tell you the ultrasound's preferred, but then they give you an MRI image, which is kind of frustrating. But this is a T1 image here, shows some hyperintensity along the tendon on the anterior ankle, and then some thickened tibialis tendon as well. Surgical referral here is going to be for debridement, tenosynovectomy, again, after treatment failure. And then overall satisfaction rate here was 92%. So I think pretty good surgical outcomes overall if you end up making it that far down the pathway. But, most patients really don't need that much. So moving on to kind of our neurovascular compressive type phenomena. So chronic exertional compartment syndrome. This is it's a patient that's going to present with intense pain, burning, numbness that's going to be worsened with activity, relieved with rest. Pathophysiology, again, there's different thoughts, but exercise-related muscle hypertrophy is going to lead to increased compartmental pressures, most commonly in the anterior compartment. And then this may cause local tissue ischemia that's related to the pain. Diagnosis is going to be compartment pressure testing, kind of provocation studies pre and post exercise. Your diagnostic criteria are going to be pre-exercise values of 15 millimeters of mercury, and then at 1 minute post-exercise 30 millimeters mercury, and then 5 minutes reading of greater than 20. Treatment here, the main thing is just going to be activity modification, shoe and gait modification, anything you can do to really lessen the workload that those muscles and those compartments are getting. And then NSAIDs and ice and stretching can play a role as well. Surgical referral, as we know, is open versus endoscopic fasciotomy, of which about 90% of patients return to equal or higher level of sports. So I think that's pretty good surgical outcomes as well here. And then popliteal artery entrapment syndrome. There are 5 different types, so we won't go into the details of this, but just to give us an idea of what's out there. Classic patient, maybe a young male, maybe a weightlifter that's going to present with claudication type symptoms in the calf or foot, correlates with intense physical activity. So you can kind of imagine this may be difficult to distinguish from exertional compartment syndrome. Pathophysiology, like I mentioned down here, could be an abnormal vessel course, congenital tendon anomaly, muscular hypertrophy causing compression. Your gold standard diagnosis here is going to be MRI and MRA with provocation studies possibly needed, just to kind of assess the vascular structure there. And on this image, you've got the small arrow here. This is a T1 image showing the popliteal artery being compressed, and then you have the medial head of the gastroc here with the long arrow. If you look at it kind of grossly, it looks a little bit lateralized. So I think that's where the compression is coming from here. So if we look at our different types, this one is going to be the type 2. just to give us an idea. And then treatment here sounds pretty invasive. So myotomy with or without vascular reconstruction. This is a deep structure and, an area you don't necessarily want to go messing with if you don't have to, but primary graft patency rates at 1 in 5 years, they mentioned, are 96 and 92%. So, you would want that graft to stay open permanently if possible. So 92% doesn't sound great at 5 years, but if you have to do it, you have to do it. And then kind of lastly, peripheral nerve entrapment. The article kind of runs through these pretty quickly, so I've grouped them on one slide. But again, you can refer to the table or do the reading in the article itself, but just in the interest of time, put them all together. So first, the common perineal nerve, so originates from the L4 to S2 nerve roots. It's going to present as distal leg paresthesias, foot drops, frequent tripping. So you may see the distribution of numbness through here on the dermatome. Diagnosis, they mentioned nerve conduction studies can be effective versus an MRI. And this is an injury you may see with a proximal fibula fracture, runners, cyclists, obese patients, anybody that has compression kind of in this general area here. Treatment's going to be activity modifications, PT, surgical decompression is also an option. And they mentioned about 80% of patients have improvement in motor and pain with this condition. Next, we've got saphenous nerve entrapment. So this is L2 to L4 nerve roots. Patient may present with chronic knee pain that's worse with flexion. So you can, I highlighted it. Yeah, you can kind of see the saphenous nerve here. You can imagine with flexion, this is a pretty superficial nerve, may get compressed between some of these muscles of the quad and cause pain. Diagnosis is going to be ultrasound versus MRI, just depending on what you need and what you can see at the point of care. Treatment's going to be activity modification, PT. They also mentioned hydrodissection could be a useful option here. And then surgical decompression, but there's no mention of surgical data for this one. And then lastly, we'll talk about the lateral plantar nerve, Baxter's nerve, or distal tarsal tunnel syndrome. So this is compression of the first branch at the tarsal tunnel that presents typically as medial heel pain. Diagnosis, you may see an MRI with neurogenic muscle edema at the abductor digiti minimi. And then treatment is going to be conservative therapies, steroid injections, and then surgical release if needed. But again, there's kind of limited surgical data there. And so just in summary, as we wrap up, chronic lower leg pain, we've gone over several conditions, some important things to consider I've put here. So bone stress injuries, exertional compartment syndrome, various tendinopathies, nerve entrapments. And again, I think the table is a helpful reference if you're kind of trying to sort between these things. And then talked a lot about imaging. So consideration of the indication for the imaging, the convenience and cost effectiveness of it is going to play a role in your clinical decision making. And then a lot of the mainstays of treatments are the same at your first visit. So activity modification, anti-inflammatory, mitigation of risk factors that may be causing these errors or causing these injuries like training errors and muscle imbalances. And then there are going to be ultrasound guided and surgical options in a lot of cases, but generally you're not going to progress down this pathway until you've tried conservative therapy for several months, usually 6 in most cases. So with that, I'll open it up to any questions and put my references up here. So thanks.
Thank you, Dr. Barton, for that great presentation. A lot of great pictures and tables that are very helpful for someone who recently took the CAQ. And I see why the Fellows Top 120 Subcommittee selected this journal. You did a great job presenting it. There's a lot of high yield information in there. So if people have questions, feel free to enter them in the chat. I don't see any quite yet, but in the meantime, I'd like to give Dr. Mark Troxler an opportunity to share any additional comments you may have to provide a third internist to weigh in on this great article.
Excellent presentation, Dr. Barton. Excellent slides. Very good article. And just want to echo about the boards. They love this article. And the boards, they don't usually ask questions directly. For example, they'll give you a distance runner with first web toe pain and tingling, and they'll ask you which compartment is involved. So you have to know, of course, which nerve, the deep perineal nerve, and you have to know it's the anterior compartment. And they're tricky like that. The other thing, since we're non-surgeons, the important thing to remember is that the important part of really the board exam and then just clinical practice is that our job is to diagnose it. And so they'll give you the exact same case, two separate questions. And one, they'll say the runner stops running and the pain stops immediately, versus the runner stops running, but the pain continues. And of course, the first one is more a claudication, a vascular, and the second one is more neurological in case. When it comes to tendinopathy, the important thing to try and distinguish between the other problems in the article is that a tendinopathy will get better with exercise. And so that's what we typically do with treatment. So for a person who has Achilles tendonitis, tendinopathy, we'll get them on an exercise bike 30 minutes before practice, get that tendon warmed up nice and loose, and then they can go and practice. Otherwise, it's too painful to even run. And shockingly, just a few minutes of stationary bike makes, all the difference in the world. And one thing, two other things is that the boards and in practice, they try and trick you to think that a case is plantar fasciitis, when in actuality, it's one of the many foot nerve neuropathies that the article goes into very details about. And then the final, there's one line in the article about bone tumors, and they'll give a case and a picture of a bone tumor, usually the tibia, fibula, sometimes the femur. And they want to know basically, amputation or not amputation. And they'll give you a case of a kid, maybe 14 years old, with night pain, and he takes aspirin and the pain actually gets better. And of course, those are all clues of an osteoid osteoma. And the most common place is the leg and the femur. And it's a non-malignant tumor, so they just go and remove the actual bone tumor. They don't have to do an amputation. And so real good article, excellent presentation, and just want to congratulate you on doing such a great job.
Thank you, Dr. Troxler, for that insight. That is, again, very valuable for all the people listening in. We're going to watch this again later, who will use this as board prep material to kind of review this article. The last thing I will want to plug is, if you have additional questions, like Dr. Barton said, reviewing the article itself and in depth wise in terms of a lot of the tendinopathies, there's another great AMSSM National Online Fellow Lecture Series that Dr. Schroeder did on tendinopathies that was extremely high yield and had a lot of great content. And it doesn't look like there are any questions. So with that, I will introduce our second presenter, who is Dr. Alexandra Piampiano and her club mentor, Dr. Jenna Walls. Dr. Alex Piampiano is the chief resident in a PGY3 in family medicine at Summa Health System in Akron, Ohio. Her medical interests include physical activity promotion, ultrasound-guided injections, sport and mass event coverage, and obesity medicine. In her free time, you can find Alex coaching high school lacrosse, hiking in the nearby national park, or cycling at Cycle Bar, or if it's the second night in Indianapolis at a Taylor Swift concert, which we talked about. Her presentation is on the article, Comprehensive Approach to the Evaluation of Groin Pain. I'd also like to thank Dr. Jenna Walls for serving as her club mentor. Dr. Jenna Walls is a primary care sports medicine specialist with Franciscan Physician Network in Indianapolis, Indiana. After graduating from Ross University School of Medicine, she completed her family medicine residency and sports medicine fellowship at Ascension St. Vincent Hospital in Indianapolis. She currently serves as a member of the medical staff that provides care for Butler University, Purdue University, the Indianapolis Indians, and the Indiana Mad Ants. Outside of her clinical practice, she is a member of the Indiana High School Athletic Association Sports Medicine Advisory Committee and is the physician member for the Indiana Athletic Trainers Board. And I will turn over to Dr. Piampiano.
Okay, thank you, Dr. Chu. So I also have a pretty dense article that I'm going to try to blow through because there's a lot of content in it, but it's all good content. So thanks again to Dr. Walls for being my mentor for this journal club presentation. I'm going to go through the comprehensive approach to the evaluation of groin pain. So starting with an overview, we're going to go through some background, a little bit of history taking, physical exam, lab work, imaging, and some differentials of groin pain. So just some background, why do we care? Why is this so important? 1 out of 4 people will develop symptomatic hip arthritis before the age of 85, and 1 out of 20 athletic injuries present with groin pain. 1 out of 10 sports medicine visits are for groin pain. So it's something that we're going to see frequently in primary care sports medicine offices. So in terms of history, obviously you want to take a good history. In terms of past medical history, what is the most high yield? Do they have any congenital disorders, any use of orthoses in childhood, history of dysplasia, any malignancies, or systemic inflammatory diseases? Social history-wise, any history of alcohol abuse or steroid use, and focusing on things that raise higher suspicion for osteonecrosis. Like I said, alcohol abuse, steroid use, but malignancy, coagulopathy, decompression sickness, those are all things that can predispose to osteonecrosis. So it's important to ask about those things. And then surgical history wise, not just ortho history in terms of surgeries, but recent GI surgeries, GU surgeries, any kind of vascular procedures, and then the timing of the surgery. How recent was it, and how does it relate to the onset of the pain? And then going back to med school, using our old cards or any other mnemonic you use to remember how to take a good history, focusing on onset, location, quality, severity, what makes it better or worse? Does it radiate anywhere? Is there any popping or clicking involved? And then do they have any systemic symptoms, any fever, any chills, any rashes? Other things to think about, what is their occupation? Are they a truck driver? Do they sit all day long? Are they into pickleball? Like I feel like most of my patients are right now. Any prior trauma history? And then thinking about sports specifically, the sports that have increased risk of early hip arthritis are those endurance sports where we put a lot of repetitive loading of those weight-bearing joints. So thinking about running sports, soccer, hockey, basketball, things where you have high impact joint loading. Physical exam wise, a basic physical exam, thinking about inspection, palpation, range of motion, strength, and then special testing. And first thing you're looking at is a standing exam. How is their posture? Is there any asymmetries that you notice right off the bat? Any masses? Any blatant atrophy, either that you've noticed or that the patients notice? A lot of times, especially our weightlifters, will notice if they have atrophy in one place than another. That's new for them. And then pelvic obliquity, which we'll get more into in the next slide. So we can estimate pelvic obliquity by facing the patient and kind of imagining the line between horizontal and the iliac crest. The most accurate way is with a full standing AP X-ray or a CT scan, but you can get a pretty good estimation from just looking at them on physical exam. So looking for obliquity is important because they could have a spinal deformity or a limb length discrepancy that could be leading to that. The other way you could have a pelvic obliquity is a functional pelvic obliquity. So you could have a compensatory change in the pelvic tilt based on a hip flexion contracture where it's tilting anteriorly, or weak abductors, so one side's kind of dropping down. Same thing with gait. So that's even including from the time they get up from the chair, walking over to the exam table. Are they really reliant on the rests of the chair to get up out of that chair? Ideally, you could see them in 6 to 8 full stride lengths, but I feel like for most people with significant gait impairments, you can see it 1 or 2 steps across the room. Is it antalgic? Is there a Trendelenburg? Are they leaning towards the affected side, moving their center of gravity? Or are they on the opposite side? And looking at what phase of the gait are they having problems. With that antalgic gait, the stance phase is what's going to be the most short, and that's why I mentioned that. So that's important to look at too. Seated exam wise, internal external rotation of the hip is best in the seated position. You're really stabilizing that pelvis and the hip to get a true range of motion for the internal external rotation. Decrease internal rotation, that's frequently the first sign of an intra-articular disease, whether it's just an osteoarthritis or a joint effusion, or if there's a contracture. The seated straight leg raise, positive if they have radicular pain caused by a stretching of the entrapped nerve root. You're going to passively extend that knee to full extension. You can also test hamstring tightness at the same time. They may be like, oh, it just hurts because you're stretching me versus I feel pain shooting down my leg. You may notice like if their ipsilateral hip and trunk kind of lean back, more likely to be tight hamstrings in that case, or if they're kind of leaning on the table for support to kind of lean away from you doing that exam. Reflexes wise, looking at the patellar and the Achilles reflex will be important as well. And I did just note down here the normal range of motion. So internal hip rotation, 20 to 35 degrees is considered normal, and then external hip rotation, 30 to 45 degrees. Supine exam, doing range of motion again. You can check internal, external rotation laying down as well as abduction, adduction, and flexion with the normals as above. Special testing wise that you can do while they're supine, testing for the Thomas test, looking for a flexion contracture. Normal if their leg is able to kind of remain flat or down on the table, whereas abnormal with a tight hip flexor, you're going to have a lifting of that leg that's straight. The Stinchfield test, you're looking for iliopsoas contracture as well. You're going to have pain with active hip flexion to 20 to 30 degrees with or without resistance. And then Faber's or Patrick test, that figure 4 position. Location of the pain is important with that one, whether they're feeling it in the groin, the SI joint, that lumbar spine kind of helps to correspond with the source of that pathology. So lateral decubitus exam, you start with Ober's test. So looking for that IT band contracture. We're going to have the unaffected side down on the table, have the knee in 90 degrees flexion. And you want to see if this knee that's being raised can drop down to midline. If it's not able to drop down to midline, you can be pretty confident that there's an IT band contracture. A here, you'll have the modified Ober test, looking more for tensor fascial lata contracture. B, we're looking for a glute med contracture here. You try to put your hip in neutral position and knee flexion to try to avoid that IT band and eliminate that from your exam. And then C, our last one on this test is checking for the glute max contracture test. You're going to have we're going to passively bring their hips into flexion and adduction for that one. So some more lateral decubitus exams. You could check Fadir this way. You also can check it supine, which I think is how, in my experience, people are more frequently examining that. And then while they're also on their side, you can check for approximation test, putting some downward force on the iliac crest, resulting in compression of that pubic symphysis. If they have more posterior pain, we're looking more at a SI joint. If we're having more anterior pain, you're more likely to have some pubic symphysis inflammation or osteitis pubis. Strength testing, you want to test the hip flexors. You can do that both supine and sitting. Hip abductors, single leg stance is a good way to test that, as well as having them laid down on their side, extending that back leg and pushing down, or sometimes even just letting their leg hang there. They'll be weak enough to let that fall. Hip adductors, testing that in the supine position, and extenders, you can either do the lateral or the prone position. Just a general view of sensation to the groin area. I'm not going to go too in depth with this for the sake of time. Laboratory evaluation. So if you're concerned for infection, obviously we want to get a CBC looking for an elevated white count, check for an ESR and a CRP. If you're worried about an inflammatory arthritis or spondyloarthropathy, looking to get that rheumatoid factor or the HLA-B27 that we frequently see in ankylosing spondylitis. And then down to x-rays. So a lot of times we'll get an AP looking for acetabular reversion. So looking at the angle of the acetabulum in the horizontal plane, whether or not there's a crossover sign showing retroversion. Looking for degenerative joint disease, osteoitis pubis, the pubic symphysis. And then we can also get a single leg stance or flamingo view where they'll stand on one leg, looking for pelvic instability. So greater than 2 millimeters of pubic translation is pathologic, though you can have up to like 5 millimeters in a physiologic motion in an asymptomatic patient as well. So really relating the x-rays to the clinical picture of the person in front of you. Frog leg lateral, usually we only do in the pediatric populations, looking for skiffy and leg caths in that view. Okay, lateral wise, looking for that abnormal head neck offset. So the difference between the anterior radius of the femoral head and the femoral neck, less than 7 millimeters is indicative of femoral acetabular impingement and cam lesion. And then looking at the anterior femoral head coverage. So at the VCA angle, how much of the femoral head is covered by the acetabulum in the front? Is there dysplasia? Is there a pincer? Looking at intra and extra articular abnormalities. So just even looking for malignancies, obvious dysplasia, arthritis, osteonecrosis, any kind of loose bodies or fractures. And then MRI, looking more for soft tissue abnormalities and subtle degenerative changes that we don't see on X-ray. Bone marrow abnormalities, fractures, if they're suspected but not seen on X-ray, it's important to get MRI. You can also see labral pathologies, osteomyelitis, musculotendinous injuries as well. And then MRI arthrography, most useful for labral tears, ultrasound, just touching briefly. There's a lot of use for ultrasound in the hip, but can be especially helpful for sports hernias and diagnostic and therapeutic injections. And then EMG, nerve conduction studies, can also be helpful if we're having evidence of nerve entrapment with symptoms greater than 2 weeks. There we go. Okay. And this is more for completion's sake, kind of an overview of advanced imaging based on the suspected diagnosis. So if you're worried about FAI or fracture, you can get a CT if you're not seeing it on initial X-ray. Worried about labral injury or chondral injury, you get an MRI. Same with an osteomyelitis stress fracture. You can also, if you're looking for a sports hernia, you can do an MRI or an ultrasound in that case as well. And then if you're thinking, man, I wish I knew how to read these X-rays that are so important to hip pathology. Don't worry, AMSSM's got you covered. So they have a lot of great resources on the Fellows Resource Library, as well as a whole YouTube channel dedicated to reading X-rays. And so they have them for all sorts of pathologies in MSK, including the hips. So differentials of groin pain, we're going to move kind of quickly through this because I only have 5 minutes left and there's a lot in this. But thinking about in terms of MSK causes of groin pain, you can categorize it more into intra-articular and extra-articular. So intra-articular are labral tears, chondrolysis, instability, synovitis, osteoarthritis, and then the extra-articular looking at iliofemoral ligament sprains, apophyseal avulsion fractures, snapping hip syndrome, psoas, muscle abscess, osteoitis pubis. And then more specifically looking at exam maneuvers and the intra-articular pathology that's associated with. So internal and external impingement showing some relation to FAI and labral pathology. The Stinch field that we talked about earlier, looking for intra-articular pathology like arthritis and synovitis. So isolated groin pain without any other symptoms, seems to be sports related or activity related. You can kind of narrow your differential down to hernia, sports hernia, pubalgia, osteitis pubis, adductor tendonitis, and labral tears. And then if you have radiation to the flank, and there's suprapubic tenderness and dysuria, worry about a UTI because not all groin pain is MSK related. Flank pain with radiation, with hematuria, we get worried about nephrolithiasis as well. So you can't turn off that primary care brain. With radiation to the knee and the more acute setting, for sports-related injuries with mechanical symptoms, we start to think more about labral tears and loose bodies. On the acute side, with related to trauma, is there a fracture? Is there chondral injury? And then still on the acute side, outside of sports, outside of trauma, stiffness, painful range of motion. Are they having a fever? Are they septic? Do they have a septic joint? Or without a fever, they have an inflammatory arthritis, or osteonecrosis. On the chronic side, with decreased range of motion and gait disturbances, we worry more about just osteoarthritis and osteonecrosis. With radiation to the thigh and butt, if it's acute in the traumatic setting, we worry about muscle and ligaments, strains, pelvic fractures. In the absence of trauma, we worry more about lumbar radiculopathy. On the chronic side, we can think more about osteitis pubis or SI joint dysfunction. Still thinking about stress fracture, and trochanteric bursitis as well. And then non-musculoskeletal causes of groin pain, there's a lot of them. So what are their other symptoms that they have? Are they having GI related symptoms, abdominal pain, changes in bowel or bladder habits? Then think more of GI related diseases. Inguinal masses, pain with straining, lifting, sneezing. Do they have an inguinal or femoral hernia? Suprapubic pain with dysuria and urgency, we have to think about UTI. Flank pain with hematuria, like we talked about, nephrolithiasis is on the differential. Abnormal uterine bleeding with dyspareunia and dyschezia, we have to think about endometriosis. And then pregnant females with sharp right lower quadrant pain with radiation to the groin is very commonly seen, and that is commonly with round ligament pain. And so this is just an overview of more non-MSK causes of pain. I won't belabor it too much, just hit some of the things that we haven't talked much about. So if they're having acute GI pain with pulsating masses, we should be worried about a AAA, something pretty urgent there. Other changes in bowel habits in an acute setting. Do they have an appendicitis? Do they have a diverticulitis or a psoas abscess? In terms of acute gyne causes, PID, ectopic pregnancy, all things that you'd want to rule out with someone with groin pain as well. And then here's my sources. The starred one is the star of the show, the article I presented, and then just a few extra resources I used in making the presentation. Any questions?
Thank you again, Dr. Piampiano, for that excellent presentation. I think the groin is also very challenging, and I think a lot of the physical exam and special tests you had in there with the associated pictures was super helpful for learners. And as I wait for any questions in the chat, I'm going to turn over to Dr. Walls for anything you would like to add regarding this presentation.
Thanks, Justin. Yeah, great job, Alex. Part of the reason why I like this article or pick this article is because it is a great reminder that not all groin and hip pain is musculoskeletal. And as a sports medicine doc, I very easily forget that sometimes, you know, having been in primarily sports medicine practice for the past 5 years. One of the things that you mentioned in the presentation, or that you put a picture of, that I think is really key, is something that I remember from boards, is the C sign for groin pain or hip pain. So that idea of when you ask the patient where their pain is, they'll make a C shape and kind of put it right in that anterolateral aspect of the hip. I remember that being something that, you know, I was specifically asked about in both family medicine boards and sports medicine boards. So I liked that you put that image in there because I thought that was key. So, but great job.
Yes, and Dr. Troxler would like to mention also remembering varicocele as part of the differential diagnosis as well. So like you mentioned, keeping a broad differential in terms of like GU pathology as well. So it doesn't look like they're
Quick question.
go for it.
And so, there's a mention of sports hernia. And so unfortunately, in practice, what happens is patients have groin pain and they go to urology, and urologists are not the best at fixing hernias or know much about inguinal hernias, much less sports hernias. And varicoceles are very common. And so they attribute the groin pain because their inguinal exam is normal for inguinal hernia. They have a varicocele, so they fix the varicocele. Well, the pain continues because it's a sports hernia. And if they really examine closely, and this is very important in the boards, they'll have posterior inguinal canal pain. And if you do an MRI, you'll see a tear in the rectus abdominis and the conjoint tendon. And so it's a very elusive diagnosis, sports hernia, and very commonly misdiagnosed and a very favorite board question. So don't get distracted by varicocele. That's typically never the right answer.
Thank you for that insight again. And it doesn't look like there are any more questions at the moment. So I would just like to, again, thank our two presenters as well as their two mentors for these excellent presentations today. I've enjoyed moderating this and being a part of this experience as well. It was a pleasure serving as that moderator, and I'm pleased to announce that there is going to be another AMSSM Journal Club meeting that will be held Thursday, December 5th at 8:30 p.m. Eastern Time, and I hope you will make plans to join us again. And this concludes tonight's meeting.